I think one of the most common questions I get is, what am I allowed to eat during pregnancy? That's like the biggest one I get. Like, what can I eat? What can I not eat?
Welcome to Wisdom Beyond the Womb. I'm Trisha Harris with Trisha Harris Photography, and today we're sitting down with providers from Hibiscus Women's Center. Hello, ladies. How are you?
Hi, good. How are you?
Good. Please introduce yourselves.
I'm Annette Sandoval. I am the lead midwife at Hibiscus Women's Center.
And I'm Dr. Heather Lopez. I'm one of the newer physicians that joined Hibiscus about a year ago.
Thank you guys so much for being here. I'm really excited to have you and just for you to share your insight on all the prenatal care that you guys offer. Tell me, when should somebody come to your office when they find out that they have become pregnant?
Normally at our office, we start our first prenatal visit around 8 weeks. Patients can come in and expect to have an ultrasound, which we call a confirmation visit, a viability scan. So you'll see one of our ultrasonographers first. We actually have two in our office. They're both wonderful, Kelly and Brianna. They usually start by doing an ultrasound to confirm that the pregnancy is inside the uterus, matching dating for someone's last menstrual period. And then after that, we then usually are seen by a physician or a midwife, where we kind of go over what to expect for your new OB visit. So kind of that 8 to 9 week mark is when we first bring you into the office. Obviously sooner if something's going on, someone's having vaginal bleeding or issues or things like that.
I'm sure a lot of people don't know. What's the difference between the midwife and the doctor?
At our practice, we are certified nurse midwives. We are nurses that have a master's degree, and we have been trained like a nurse practitioner, but with the ability to also deliver babies. We can take care of pregnant women from the time they become pregnant until they deliver and afterwards. We can also do routine gynecologic care throughout the lifespan, from teenagers all the way through menopause. The biggest difference is that we don't do surgery. So our physicians, if somebody needs a C-section, they're done by the physicians. And additionally, if we have patients who have some maybe higher risk conditions, that the midwives will work collaboratively with the doctor to manage those.
I bet that's helpful so that there's lots of care provided for the moms then. How do you handle the different birth plans? Do you guide them?
So yes, it's an ongoing conversation through the pregnancy. There's a lot of things that we already provide. The majority of patients will come in things like, I want delayed cord clamping, or I want to do skin to skin with my baby after delivery. Those are standards of care for us. One of the big things with us is we do try to be low intervention, but we are not no intervention. Obstetric care is really preventative care. We see patients early in the pregnancy every 4 weeks, after 28 weeks every 2 weeks, and at the end of the pregnancy every week, so that we can monitor the mom, monitor the baby, and see if there's any complications arising, things like gestational diabetes and preeclampsia. We only do interventions when it's necessary for the health of the mom and the baby.
What are some of the most common questions that you're asked during the early visits of pregnancy?
I think one of the most common questions I get is, what am I allowed to eat during pregnancy? That's like the biggest one I get. Like, what can I eat? What can I not eat? And I kind of go over it with patients. The first thing is thinking about sushi. That's always a big question. And I say, when you're eating sushi, just be boring with your sushi. Other things is thinking about like cheeses and milks. We want them to be pasteurized, not unpasteurized. Other things is avoiding certain fish. So fish that have high levels of mercury, like tuna, king mackerel, shark. We want to avoid those in pregnancy. And then also the biggest one is lunch meat. Yes. Lots of women tend to crave lunch meat when they're pregnant, and it used to be was like a hard no. Now recommendations are really just to make sure you're kind of steaming that lunch meat, and then you can put it on your sandwich. Same thing with like anything like meat or things like that. You want to make sure it's fully cooked and stuff like that. So that's probably the biggest question I get. What about you?
That is a big one. Exercise in pregnancy, and I get a lot of questions about just people asking, oh, I've heard this on TikTok, or I've heard this on a website, and is this true? And so I do spend a lot of time like debunking misinformation on the internet, and then also clarifying and educating, and then leading them to good websites. So for example, one of the things I tell my patients when they ask about foods, hey, a good website is the FDA Safe Pregnancy Food website. That's one that I can tell you that you can go to safely. And then also on our website, because we have a website for Hibiscus, we have links of safe websites that women can use for all types of education.
Education is key, and for a lot of women, it's their first time going through this.
Yes.
So what do you do for childbirth and preparing them for that part?
In our midwifery model, we do a lot of education. We have checklists that we do at certain visits to make sure that we hit all of the points. We provide longer visits with our patients. So our new OB visit and our 28-week visit is a 30-minute visit with our patients where we answer a lot of questions a lot of times before they even ask it. And, you know, every visit we sit down with our patients. First thing we ask, do you have any questions or concerns? After the end of the visit, do you have any questions or concerns? And education is kind of ongoing. We try not to overwhelm them at every visit. So, you know, if they come to me at the very first visit with a question about, you know, something that isn't important until later in the pregnancy, I take them to take a big deep breath and say, let's get through step 1 and then we'll hit step 2.
Do you guys offer in-person classes of any kind?
Yes, actually with Lydia Baker, who is a local childbirth educator and a wonderful doula. She has partnered up with us for many, many years and provides prenatal classes both virtually and in our office where she goes over the birthing process and additionally kind of talks about how it is with the Hibiscus midwives because she's known us for so long and worked with us for so long that she can give a lot of great information to them.
And that's special for our patients too. Like our patients have access to that, which is really nice. And it's held in our practice at night, which is super, super nice.
Yeah.
That sounds really flexible for the working parents and everything. Wonderful. So once it comes time to reaching that due date, you know, the anticipation is rising on when will my baby come? How do you control that process, because babies march to the beat of their own drum and will sometimes show up when they want to show up?
So we do have a protocol in our practice. You know, I tell people all the time, like, we always want your baby to come when your baby's ready. There are certain things why we would do something earlier, like Annette mentioned earlier, like gestational hypertension or diabetes of pregnancy. But usually we talk to moms, if we haven't had a baby by 41 weeks, we really want to bring you in for an induction. We know that not so great things happen after 41 weeks. There's actually a chart that we show in our office. I think you do this too, whenever I'm talking to patients about that induction at 41 weeks that shows the increased risk of stillbirth that literally goes like this. And so usually at 41 weeks, we tell patients if you have not had a baby, we really want to bring you in for that induction.
Yeah, and we talk about that throughout the pregnancy. Yes. I mean, we look at, you know, there are other risk factors and all of those things. But, you know, and additionally to the unfortunate increased risk of stillbirth at the end of the pregnancy, a lot of the things that women really are hoping to avoid, babies going to NICU, babies being sick, increased risk of C-section. Like I said, this is an ongoing conversation with our patients. Honestly, usually by the end of the pregnancy, most women, once they've gone a week past their due date, are very ready to have a baby.
They're asking for an induction. We're not telling them it's time. It's,
get this baby
get
out
the baby out of me. 100%.
We deliver all of our babies at Holmes Regional Medical Center. We don't go to any other hospitals in the county.
We have a NICU there. We have anesthesiologists that are on site 24/7. So we don't have to call people in from home, which is really nice because not all labor and deliveries have that, where they have all that in service. So that's kind of a perk for our patients as well.
So when women go into labor naturally, they take themselves to the hospital. Do then they have to contact you, or the hospital contacts the office for you?
So the women can call us 24 hours a day, 7 days a week. One of the midwives is always on call. The midwife who is on call does not have patients in the office that day. She's dedicated to labor and delivery for that 24 hours. For some women, they know that they're in labor and they head on in. There is an OB triage area where they would be evaluated by a physician. If they're found to be in labor, then they contact the midwife that's on call. We're usually already in-house, and we take over for the labor management. And like I said, sometimes, you know, patient will call and be like, you know, I'm having contractions, but I'm not sure, usually first-time moms. And we encourage them to call to make sure that, you know, they are really in labor. And we ask them a bunch of questions on the phone, make sure baby's moving well, things like that, and help them make the decision of when to come into the hospital.
So you mentioned how some women might not realize they're actually in labor, right? Yes. And that can be scary. But it can also be scary with the induction process because it's unknown as well. Sure. So what does that look like? What is the process?
Absolutely. So induction can look very different for different women, and it honestly all depends on what their cervical exam feels like. So one of the things that we do is we check the cervix for dilation and for something called effacement to see how thin the cervix is. If somebody has, especially for medical inductions, if somebody's cervix is what's called long, thick, and closed, meaning that it is not even ripe and ready for labor, we have to do something to help get that cervix ready. Pitocin is a medication that we use for contractions. However, if you give it to somebody with a closed cervix, it's not going to do anything. So we have to soften that cervix up and help it open up a little bit. And the way we do that is with medications that are called prostaglandins. One of them is called Cytotec and another one is called Cervidil. These are medications that are inserted vaginally to help soften up the cervix. It basically has the cervix kind of absorb fluid in it, and it breaks up the matrix a little bit, gets it nice and soft and start to dilate. Another method that we can use is mechanical dilation, which is a process of inserting a little catheter inside of the cervix and blowing up a balloon inside. And that balloon actually puts pressure on the cervix, and that also creates prostaglandins, and that is a nice gentle way to get things going. Oftentimes we might do both things. We might do the Cytotec and the balloon. We are gentle in the process. We don't rush the process because we know this can take a long time. For some women, it happens really quickly, and for some women, it can even take 2 days. But we are very, very, like I said, patient with the process. Labor officially starts when you are 6 centimeters dilated, contracting regularly, and making change in your cervix. So getting us to that 6 centimeter point is not labor yet. That's still part of the cervical ripening. And so we don't actually start the clock ticking on a labor until once we hit that 6 centimeter mark.
How long are they allowed to labor until a C-section is necessary?
So I think that's a difficult question. I think it always, we have to go back to look at the patient. It really depends on if it's a first-time mom, second, third-time mom. But once you hit 6 centimeters, you really should be making kind of more rapid change in your cervix. Like Annette said, it can take a long time to sometimes get to 6 centimeters. Once you're there, you should be making a centimeter change every 1 to 2 hours. So we kind of define a rest of dilation, meaning that we're not kind of progressing. If someone's been anywhere from like 6 to 9 centimeters or not progressing past there, and they're stuck there for either 6 hours on Pitocin with good contractions or sometimes 4 hours. It just kind of depends on kind of what's going on with the patient. But, you know, we're always talking with the patient, letting them know what's going on, kind of keeping them in tune. And it's also monitoring baby and how baby's tolerating this long labor process. We're really, in some ways, lenient on that too, that we really want vaginal deliveries for our moms. That's really important. But we also want a healthy mom and healthy baby at the end of the day.
And I would also touch base on, like, because I hear it a lot, and maybe you guys do too, is, well, I really love Dr. Lopez. I want Dr. Lopez to deliver my baby, right? You know, we can't time labor. So how do you handle that request and everything?
So yeah, I mean, I've been here a long time, and I've done a lot of deliveries for Hibiscus. And for example, I'll have a patient who maybe I delivered her last 2 babies, and she's like, "Oh, Annette, I really wanted you to deliver and oh, I would love to deliver your baby." But we have our practice structure for several reasons. One of them is that you know, we do 24-hour call shifts, and those shifts are long, and you know, we can't do 2 shifts in a row. That's not safe, and we have to maintain kind of the schedule of the practice. I have found in the past that, you know, somebody who desperately wanted me to deliver them, when they were delivered by, say, Katie or Ingrid or any of our other midwives, just come back and say, "Oh, they were so wonderful, and I'm so happy, and thank you so much, and I'm glad that I got to be delivered by 2 Hibiscus midwives, not just 1.
So we talk about trends a lot, right? You mentioned with social media and stuff, and it seems like a trending thing with delivery are VBACs. How do you guys handle those?
We are open to VBACs. You know, we are big about talking to patients about risk and kind of going through why they had their first C-section. That's the biggest thing. You know, usually what happens is our midwives will see them for their new OB visit, and then what will happen is they'll say like, "Oh, this patient's a C-section, she wants a VBAC. Well, you should have a consult with a physician." So usually the physicians take over that visit. We sit down, talk about the risk associated with VBACs, why they had their first C-section, and whether they're a good candidate or not. I'm very open and honest with my patients, and someone who's come in, tried to have a vaginal delivery, pushed for 4 to 5 hours, baby wasn't coming down the pelvis, I'm very honest that maybe that's not a great patient for a VBAC. Other patients that have had, you know, a breech baby, or say they were laboring and baby's heart tones dropped, those are great candidates for VBACs. I think we're very, very honest with who's a good candidate and who's not, and that's not because we want to do C-sections. We love VBACs. VBACs are great for people when they're successful, but we want to take good care of the mom and the baby.
Yeah, and you know, again, education and conversation throughout the pregnancy. You know, when we have a vaginal birth after C-section, patients, it's called a TOLAC, a trial of labor after cesarean. You know, it's very important, you know, they're continuously monitored. You know, we are, you know, very... if the labor starts to not go well early on in the labor, we're gonna opt for that C-section sooner than we would if everything's going swimmingly with the labor. And like Dr. Lopez says, very dependent on why they had that prior C-section. We would obtain their records if they didn't deliver with our practice, because a lot of patients with prior C-sections do seek us out in the hopes that they can have a vaginal delivery with us. But we are absolutely supportive in the appropriate patients to attempt a vaginal delivery after cesarean in our practice.
So where can we find out all the things for Hibiscus? Do you guys have web pages? Where's your office located? And social media?
We have a great website with lots of information, all of, our pictures. You can see everybody, read their bios. It's wonderful. Where our prenatal guide is.
Yeah, that's hibiscuswc.com.
We also have a Facebook page, which is great, where we're always posting, information about our midwives, babies we delivered, and things like that. We are located right off Hibiscus. We're literally maybe less than a minute drive to the hospital. So it's really, really close to the hospital, which is really nice.
It's been great talking to you ladies today. Thank you so much.
Thank you.